Hello, everyone, and welcome to the TMA Ask the Expert podcast series. Today's podcast is entitled Imaging Patterns in Myelopathies and Myelitis. My name is Gigi DeFibri, and I will be moderating this podcast. The TMA is a nonprofit focused on support, education, and research of rare neuroimmune disorders. You can learn more about us on our website at myelitis.org. This podcast is being recorded and will be made available on the TMA website for download and via iTunes. During the call, if you have any additional questions, you can send a message through the chat option available with GoToWebinar. For today's podcast, we are pleased to be joined by Dr. Eoin P. Flanagan. Dr. Flanagan is an associate professor of neurology and consultant in the departments of neurology and laboratory medicine and pathology at Mayo Clinic in Rochester, Minnesota. He completed his medical school training at University College Dublin in Ireland in 2005. He completed medical residency in Ireland and became a member of the Royal College of Physicians of Ireland in 2008. He then pursued neurology residency at Mayo Clinic in Rochester and is board certified in neurology in the US. He completed fellowships in autoimmune neurology, multiple sclerosis, and behavioral neurology at Mayo Clinic. He received a master's degree in clinical and translational science at Mayo Clinic. He works in the autoimmune and multiple sclerosis neurology clinics and the neuroimmunology laboratory at the Mayo Clinic. His clinical expertise and research is focused on the diagnosis and management of autoimmune neurological disorders with an emphasis on inflammatory autoimmune spinal cord disorders and their mimics, including their MRI patterns. He also has an interest in the epidemiology of inflammatory demyelinating diseases of the central nervous system and autoimmune neurologic disorders. Welcome and thank you so much for joining us today.
Sure, thanks very much for the opportunity to speak today.
Great, so to start, just kind of broadly, what is imaging and what is its role in diagnosing myelitis and myelopathies?
Well, I think when we think about spinal cord imaging, the most common modality that we use is MRI, and that's really where some of the interest I have in myelitis has started. The MRI can be very helpful in that when we see the pattern of abnormality on the MRI, it can often give us a clue to what the underlying cause is, be it an infection, be it inflammation, be it a problem of blood vessels or a stroke in the spinal cord. So really the MRI can be quite helpful. We often, when we do an MRI, we will often give contrast, which we term gadolinium contrast. And this can often reveal a certain pattern that can be suggestive of the underlying cause. So I think when a patient has a first episode of transverse myelitis, it's really important that the MRI be done with and without this gadolinium contrast. And what we've recognized is that some of the patterns can lead us down the right track towards the correct diagnosis. It's known that some people who have this enhancement or this gadolinium deposition that we see on the MRI, that's often associated with inflammation, but we can sometimes see it in non-inflammatory causes like vascular causes from a stroke or other causes. So, but the pattern of abnormality can be quite helpful.
Great, thank you. And can you just talk a little bit about what the difference kind of between when we're talking about myelitis versus a myelopathy more generally?
Yeah, so I think those terms are a little bit interchangeable. So when we think of the term myelitis, it suggests inflammation. The itis at the end is something that we recognize in medicine to be inflammation. And myel, M-Y-E-L, is a term that we use for spinal cord. So myelitis means inflammation of the spinal cord. Myelopathy is probably a broader term which just means disease of the spinal cord. And it doesn't mean necessarily that it's from inflammation. It could be from, again, a stroke or some sort of other process, a tumor, or lots of other different processes that can affect the cord. So the itis refers to inflammation, and that's where it comes into transverse myelitis, the transverse being across the spinal cord, so representing inflammation across the spinal cord.
Okay, great, thank you. And I know you talked a little bit about contrast, but can you just expand a bit on, what the purpose of contrast is and when someone should have it, and when someone is told that they have, contrast enhancement, what does this mean?
Yeah, so again, the contrast we're talking about with MRI is gadolinium. With some other scans like CT scans, it's iodinated contrast. It's a little bit different. So if you have an allergy to a CT contrast, that doesn't mean that you will not be able to receive the gadolinium contrast. The utility of the contrast is that when it's present, it suggests that there might be some inflammation, such as we would see with an autoimmune process affecting the spinal cord, or such as we might see with an infection affecting the spinal cord. I think it's useful for patients to receive the contrast if they do have an episode of myelitis, as I mentioned earlier, because often the pattern can be helpful, or the presence or absence of the contrast being present can be helpful to suggest more inflammation than less likely inflammation if there's no evidence of any contrast enhancement. So what often happens is patients, when they initially present, an MRI will be done and there'll be evidence of lots of contrast enhancement, which would mean active inflammation. And then maybe 6 months later, if they have a repeat MRI, that active inflammation may have gone away and there may no longer be any evidence of contrast enhancement.
Okay, great. Thank you. And can you miss lesions with MRI if contrast is not used?
I think so, yeah. Sometimes we will see some contrast enhancement of the covering of the spinal cord, which we call the meninges, or the outer layer of the spinal cord, and that can often be missed if you don't do an MRI with contrast, or small little lesions may not be seen. So the gadolinium can be helpful in that things that are missed on the initial sequences may be picked up, and also the pattern then can help suggest what the underlying cause is.
Okay, and are there any health risks or side effects that are associated with gadolinium enhancement when you actually get contrast?
Well, the gadolinium contrast appears to be safe. There's no patients that I'm aware of that have ever developed confirmed symptoms from gadolinium. Now, we know that when patients get multiple MRIs, 10, 20 MRIs over time, sometimes we can see some deposition of the gadolinium metal within the brain, but it's never been shown to cause any symptoms in anybody. And, particularly in a patient who has a spinal cord problem where there's a lot of risk to their function of their walking and their urinating and lots of different symptoms, it's quite a serious condition. It's really important that patients do get the contrast initially, because it really can help the doctors determine what the underlying cause is. So the FDA is interested in this gadolinium and why there may be some deposition in people who have 10, 20, 30 MRI scans, but really it's never been shown to cause any symptoms. And for now, we still recommend patients receive it, particularly at the initial episode. When you're getting multiple MRIs over time, such as a patient who has MS, then sometimes in future MRIs, you may just use non-contrast and not use the contrast. But when you're first present with a spinal cord problem, I think it's really critical to get the contrast, yeah.
Okay, great. And then what about if you're, if for example, you've been diagnosed with something like idiopathic transversemyelitis, but then you later go on to have, new or worsening symptoms? Would an MRI with contrast be something that would be suggested, or without contrast?
I think we would suggest contrast, because in some patients like that, the presence of contrast enhancement after that prior inflammation is gone could suggest a new inflammatory area and might again help us understand the diagnosis. But, I think with some of these myelitis cases, if there's not new symptoms, then, and there's some monitoring going on where there's been lots of monitoring for many years, in some of those cases, for those later MRIs, you may not need the contrast. But if there's concern for recurrence or concern for new symptoms, I think the contrast is helpful.
Great, thanks. And we get a lot of questions from our community about, how these imaging results are interpreted, or how they're described by their physicians. So people, have questions about what the difference between a lesion or a scar or demyelination is when seen on MRI. Can you explain a little bit about these terms, or whether they're interchangeable, or how they relate to one another?
Sure. So I think when we look at an MRI of the spinal cord, we're looking inside the spinal cord and we're looking for evidence of abnormality, so that the spinal cord looks abnormal. And that's usually termed a lesion, or something present in the spinal cord that should not be there. I suppose that could be used interchangeably with a scar. The myelination is a little bit difficult because it's difficult, and I know this is a question that may come up later, but it's difficult to image the myelin for sure. So we often can just tell from what we know about how a lesion looks, whether it's likely to be demyelinating, such as MS or another disorder where the myelin, which is the covering of the nerves, has come off the nerve surface. But it's quite difficult for us to tell. That's something that really needs to be looked at under the microscope. But I think a lesion, a scar, is interchangeable. I will mention that we are interested in looking at how the lesions change over time. So if someone has an initial episode, say, of transverse myelitis, and there's a large abnormality within the spinal cord, in some patients, that abnormality goes away completely. So it doesn't really leave a scar, while within, for example, multiple sclerosis, it often does lead to a scar, and those patients are more likely to have problems down the line from those lesions. So it's an area of active interest, that something that I'm interested in and others are interested in terms of if the lesion does leave a scar, is that going to be more of a problem down the line?
Okay. And then, so in relation to MRIs, what does the word Tesla mean? Should someone have an MRI with a certain Tesla?
The Tesla is related to the magnet strength, and I'm not a physicist, but in general, I think a lot of the MRIs of the spinal cord are done with 1.5 Tesla. For the brain MRI, we found that 3 Tesla may be a little bit better, but I don't think that's been shown within the spinal cord. And now on a research basis, we're getting stronger magnets, which give us a bit of a better picture. But really, for the spinal cord, there is more difficulties in imaging the spinal cord because you have lots of the other apparatus that you have to go through, like movement artifact from breathing, or the heart is beating. When you image the brain, it's a lot easier. There's a lot less of those things that can interfere with the magnet. So I think in general, if you have a 1.5 Tesla magnet, which is probably pretty typical, that is, would be reasonable to look at the MRI. There are other things like when patients are in the MRI, if they can stay as still as they can, that can improve the quality of the image. So there are other things that can also help ensure that the quality of the image is good.
Okay, great. Thank you. And then we did get a question about what diffusion tensor imaging is and its potential role in diagnosis. Can you talk a little bit about that?
Yeah, I think that the diffusion tensor imaging, and again, I'm not an expert on this, but it's more of a research tool, and it looks at some of the tracks that go up and down. So, the tracks within the spinal cord are like cables that go up and down, and you can image them more closely with diffusion tensor imaging and see which tracks are affected and how that suggests what the underlying cause would be. But this is not something that's usually used in the clinical setting. So in a patient who comes into the hospital, we generally use the more routine MRI sequences, and diffusion tensor imaging is something on a research basis that helps us understand what the disease process is, and that might give us more insight into why things happen, what treatments might work, how we can better understand patients who get inflammation within the spinal cord.
Okay, great. Thank you. And then do different forms of myelitis, for example, transverse myelitis or myelitis associated with neuromyelitis optica or the MOG antibody, appear different on imaging?
They do. There are important differences. So some of these terms overlap, so I think it can be difficult for patients and even for doctors to follow these. The term transverse myelitis is a syndrome, which means that there are lots of different causes. Just like a patient who has chest pain and comes in, it can be from their heart, or it can be from their lung if they have a pneumonia, or their heart if they have a heart attack. Similarly, transverse myelitis can be from lots of causes. So it can be from an infection, it can be from an antibody. And what we've looked at is with some of the antibodies, there's one called MOG, as you mentioned. The pattern can be a little bit different than we see with another cause like MS. So, for example, with the MOG antibody disease, we see more of a central lesion involving the middle part of the spinal cord, while with MS, the areas of abnormality are more often in the periphery of the spinal cord, in the outside, and they often extend over less of the spinal cord. So we often use 3 vertebral segments. So in your back, you have vertebrae, and we determine the length of the lesion. And we know that if a lesion is longer than 3 vertebral segments of your back, then that suggests it's not from MS and it's from one of these other causes. And that would be one of the antibodies would be MOG antibody. Another one would be the aquaporin 4 antibody that's been associated with neuromyelitis optica spectrum disorder. And again, ADEM is more of a clinical syndrome. So that, patients with ADEM can have one of these different antibodies. They can have the MOG antibody or the aquaporin 4 antibody. So it gets a little bit confusing, but I think we can distinguish based on the different diseases that we know that cause transverse myelitis. So MS, aquaporin 4 antibody, NMO spectrum disorder, MOG antibody, and then the acute flaccid myelitis can overlap a little bit with the MOG antibody. So sometimes there can be some overlapping features there. They both involve the central gray matter of the spinal cord and sometimes can look similarly. So I think if you have a patient with the acute flaccid myelitis that's been associated with enterovirus, then you want to consider testing for the MOG antibody in particular because the imaging can look quite similar.
Okay, that's a great point. And then what about between these kind of inflammatory conditions rather than vascular causes of spinal cord damage? Are there any differences that show up in imaging?
Definitely there are. There's a special type of sequence that you can use to look for a spinal cord stroke. It's called diffusion-weighted imaging, and that can be useful in the acute setting because that usually shows abnormalities of a stroke. We use it often in the brain. It's not as easy to do in the spinal cord, but it can be done and can be helpful. Sometimes also for other vascular causes, you can see swollen veins within the spinal cord or right next to the spinal cord that suggests that there's a problem with the arteries and veins, such as in what we call a dural AV fistula. So sometimes you can see abnormalities there, or sometimes the pattern of gadolinium enhancement. Dr. Nicholas Zaleski, who's been on this podcast before, had reported a pattern where there was a missing piece of that enhancement within the lesion that can be suggestive of a fistula. So there are important differences, but there are also overlapping features. So we find many patients who have received a diagnosis of transverse myelitis, it turns out that they do have a vascular cause. They do have either a spinal cord stroke, or they may have an abnormality of the arteries and veins. And sometimes because of the presence of this enhancement with the gadolinium, the doctors get confused and think it's more of an inflammatory cause. So what I would say is that in patients who present with these symptoms, that they really want to think about these other types of causes that can affect the spinal cord, because there are many overlapping features and it can be quite difficult to distinguish them.
Okay, great, thank you. And then can you tell from imaging, I know you talked a little bit about this, but how likely it might be for someone with who is diagnosed with transverse myelitis to go on to develop something like multiple sclerosis?
Yeah, I think we can get a good sense. You know, the lesions in MS on the MRI generally, as I said, are short, so they don't extend over a long part of the spinal cord, only over a short segment, less than 3 vertebral segments. And they're often in the periphery of the cord, which means they're in the outside rather than in the center. And if you have multiple of these short peripheral lesions in the spinal cord, that is highly suggestive of multiple sclerosis and predicts a higher likelihood of going on to develop MS. If you just have one short lesion, then it's difficult. And if there's no lesions in the brain or elsewhere, then we have to follow those patients. Sometimes we'll repeat the MRI down the line. We'll follow them and see if they develop a new episode that confirms MS. So in some cases, it's hard for us to predict, and then we have to follow the patient over time. Okay.
And then can imaging appear normal in these conditions? So if someone presents and their physician is thinking it's maybe transverse myelitis, can the MRIs be normal and then they still be diagnosed with transverse myelitis or one of these other conditions?
Yes, I think it can be. That would raise a bit of a red flag for a couple of things. One is in the very early stages of a spinal cord stroke or spinal cord infarct, the MRI can be completely normal. And then if you repeat it many days or a week later, you may see the abnormality come up. So that's one situation where the MRI may be normal, that is a mimic of transverse myelitis or inflammation, but is actually a stroke within the spinal cord. Other times, if you image the patient too early, so say if the patient has their symptoms and you image them a half an hour or an hour after their symptoms, the lesion may not have fully developed yet. Or if you image them late, a few months after they had the episode, then the lesion may have resolved completely and you may not see it. So it depends a little bit on the timing also. And also you really want to look out for a spinal cord stroke if the initial MRI is normal. If the MRI is completely normal, then you always want to think, and if you do a repeat MRI and it's still normal, then you want to think, are we sure this is myelitis, or is there a problem elsewhere? For example, in the nerves, there's other diseases like Guillain-Barré syndrome, where it affects the nerves and not the spinal cord, but it can present similarly. Or is there other issues going on that are not neurologic related per se?
Okay. And then who reads or interprets the imaging from an MRI, and what happens when someone's doctors maybe disagree about the imaging results?
Okay. Well, I think in general, there's a radiologist, and at Mayo Clinic we have neuroradiologists who are experts in neurologic disease only. In other places, it may be a general radiologist. A lot of times, MS doctors will read their own MRI. And this is because we have experience with, we see lots and lots of patients with MS and with related conditions, transverse myelitis and other disorders. So a lot of times we'll look at our own MRI. And what I encourage all our neurologists out there to do is to look at the MRI themselves and look for these different patterns, because we've reported that the pattern of abnormality can be quite suggestive of the underlying cause. And, if you look yourself, the radiologist may not be aware of some of these patterns, but as an MS physician, you may be more aware and more experienced than the radiologist. So I think we often encourage our doctors, neurologists, to look at the MRI themselves. And that can happen if the radiologist is not experienced. Then sometimes the neurologist can say to the radiologist, well, this looks to me like it might be aquaporin 4 antibody or mog antibody as a cause. And a lot of times, we'll discuss back and forth and usually reach a consensus about what we think. So in cases where, where our radiologist says they think it's one thing and I disagree a little bit, I'll talk to them, and sometimes they'll make a change in their report to reflect what I said. Or other times they'll explain to me what they meant, and I'll agree with them, and I'll say, oh yeah, that was just an artifact, for example, from movement, and it wasn't really an abnormality. So usually that's a time for the doctor and the neurologist and the radiologist to chat and kind of go over things and try and reach a consensus. Yeah.
Okay. And then, so when someone has been diagnosed with one of these conditions, are there any guidelines for how often someone should get an MRI after their diagnosis?
So I think it depends a little bit on the underlying cause. So if a cause was found, for example, the MOG antibody, the aquaporin 4 antibody, then oftentimes with those patients, we only image them when they have a problem. So we will, if they've found a definitive cause, everything fits well, then if they develop a new episode, then that will be a time where we would repeat the MRI, develop new clinical symptoms. On the other hand, we know that with patients who have MS, for example, that they can get new lesions even if they don't have symptoms. And in that situation, we will sometimes monitor the MRI to see if they're getting lots of new lesions. And if they are, then maybe that suggests that the medication they're on is not working. If there is no cause found, then probably routine repeat imaging is helpful. So for example, if a patient develops some symptoms, you don't know the cause, repeating an image in 3 to 6 months can be helpful, because if the inflammation is all gone away or the changes are all gone away, that might suggest it was a one-off inflammation such as a virus or an antibody. While if things are getting worse over time, that might suggest, is this something else? Could this be a tumor? Could it be sarcoidosis? Could it be some sort of other condition that, we weren't able to pick up right away, but now we're able to get a better handle on things? So I think repeating imaging when you don't know is helpful. And also sometimes patients who have an initial episode of transverse myelitis will go on to develop MS. And if you repeat the imaging down the line, you may see new lesions within the brain or within the spinal cord that help you make that diagnosis. Because I think once you make the diagnosis, it can be very helpful for patients to know what the cause is, and then you know what you're treating and know how to approach the patient. So it depends a little bit on the underlying cause, and that can guide you about the repeat imaging.
Okay, great. Thank you. And so for someone with, idiopathic transverse myelitis, or what they think is maybe a monophasic situation, is there any benefit to getting routine imaging done? And if so, how often would this be the case? Would it be once a year, every other year?
Yeah, I think if there is a concern that this might develop into MS, for example, it's a short lesion, or there's some changes called oligoclonal bands in the spinal fluid, then repeating an image in 6 months or a year of the spinal cord and the brain might be useful to see if you're developing new lesions that can confirm that diagnosis. If, there's no cause found and it really doesn't look like MS and it looks like it might have been a virus or a one-off inflammation and all the tests are negative, then repeating the imaging on a routine basis may not make much difference, because if you're not developing new symptoms, it's unlikely that there'll be new changes on the MRI, and that might not be that beneficial for patients.
Okay. And then how does imaging relate to prognosis? So does the way someone's spinal cord looks on imaging relate at all to how they maybe function in their day-to-day life?
I'm not sure how well that has been studied, but I do know that sometimes if we see a lot of what we call thinning in the spinal cord, it's called atrophy, which means that the spinal cord shows a lot of damage. That we usually see that where people have had more severe episodes. So the MRI tends to look similar to what the patient has. Although in some diseases like sarcoidosis, the MRI often looks very, very nasty, but the patient is not quite as bad. So sometimes the mismatch between what the patient looks like and what the spinal MRI looks like can be a clue to the diagnosis. The other thing to mention is that some people who have a myelitis episode, if it's the first episode of MS, those patients can go on to develop what we call a secondary progressive course. So sometimes in those cases, that spinal cord lesion may contribute to some progressive disease, and we've reported on some of that in some patients where they have one lesion that then progresses over time, and there might be a question about this later, where the patient progresses from that lesion, and a lot of those end up being multiple sclerosis as the underlying cause.
Okay, and so we did talk a little bit about, what to do if someone was diagnosed with one of these conditions and then had a worsening of symptoms, but I have a specific question from someone in our community. So 23 years after their original diagnosis of transverse myelitis, they now have what their GP says appears to be further deterioration in their condition. So they've lost all power in their right leg where they previously had some strength.
Sure.
What would be recommended, in a situation like this in terms of imaging or getting to a diagnosis?
So I think at that stage, then you're really going to be concerned about that initial episode being an episode of MS, and now the patient has got a secondary progressive cause. There is a form of MS that some people use a term, it's called single attack progressive MS, which means patients just have one episode, and then from that lesion, from that scar in the spinal cord, they develop progression from that lesion, and it results in worsening over time. So I think now that patient should probably undergo a repeat MRI of the head, the cervical, and the thoracic spine with and without contrast to see if there are other lesions suggestive of MS, and the spinal fluid may also be helpful to see if there's evidence of oligoclonal bands, to see if this could be something along the realms of secondary progressive MS. And that's important because recently we have now discovered that there are new medications available for some of the progressive forms of MS. So in the past, we didn't have medications for that, but now that we do, it would definitely be worth kind of trying to figure out that further, yeah.
Okay, great, thank you. And so another question came in. This person was diagnosed with TM this past December, and their subsequent MRI done in April showed a persistent cord signal abnormality with no improvement and increase in the extent of cord involvement, as well as slight enhancement along the right edge of the cord not seen previously. Is this normal? No further treatment has been offered to them, but they do have a repeat MRI booked for October.
So this would raise a red flag to me. This would say to me, because the previous diagnostic criteria for transverse myelitis state that the patients should not worsen past 21 days. And similarly, the MRI should not get worse over time. Now, it's not uncommon for a scar to be left within the spinal cord, so the imaging may not resolve completely. But if the imaging is getting bigger and there is more enhancement or ongoing enhancement many months after the episode, with MS and with many of the other inflammation disorders, the enhancement will be gone away within 3 months. Almost 98% will be gone. So if you have persistent inflammation on your MRI many months later, that's a situation where you need to reconsider what the diagnosis is. Is this really transverse myelitis? Because this would not fit well. And at that situation, you want to consider, could this be something like sarcoidosis, which can cause this slow, gradual progression over time? Could this also be from compression of the spinal cord from our discs, from arthritis in the neck, that can sometimes cause this more progressive form over time, that can sometimes be associated with some mild inflammation that doctors mistake for transverse myelitis when it's actually due to the degenerative disc disease? Or could it be something else, some other a type of disorder, a vascular disorder like a dural AV fistula would be another thing we would think about, or less likely some sort of tumor. I think that would be a little bit less likely because they're quite uncommon. But really, that would be a point where I might seek an expert opinion at a territory referral center who deals with a lot of transverse myelitis, like Mayo Clinic or other territory referral centers around the country where they have, dedicated clinics to see if there might be a different cause. Yeah.
Okay, great. Thank you. So another question we got is this person's daughter has MOG antibody-associated disease and has continued to test positive for almost 3 years despite preventive treatment. The question is it possible that MOG could be a progressive illness like with MS? They ask this because on several occasions their daughter seems to be having a relapse, but no new inflammation has been shown on MRI, and this is both with and without contrast. And she's also had issues with vision, loss of peripheral vision. So, yeah, if you could comment on that.
Yeah. So, with the MOG antibody disease, there has not been really any cases or 1 or 2 cases where they had progressive disease, this secondary progressive form that we see with MS. So we really think that that's not something, although it's not been fully well studied yet because this is a new disease, but we really feel that this is not something that patients tend to get. Now, on the contrary, in patients who have had transverse myelitis associated with the MOG antibody, sometimes we can see worsening if patients get a viral illness. For example, if they get the flu or if they get some other virus that is common in children, this spinal cord can be a weak point for them and some of the symptoms can come back. And in that situation, the repeat MRI can be normal. So, I would be concerned about something like that. In general, with MOG antibody disease, at least in my experience, when they do have a relapse, which they can have more of a relapse, they can go on to develop a relapse, the MRI will usually show changes that are confirmed. Now, also, it depends on the quality of the MRI. Was the patient able to stay still during the MRI, etc.? But that's something, we usually see. Now, with MOG antibody disease, the antibody may remain present, and that predicts an increased risk of relapse, but it doesn't mean that they're guaranteed to have a relapse. So we do see some patients where the antibody is still there, and we tend to treat them based on their clinical symptoms rather than treat the antibody. So we look and see if they have developed new episodes. And in regard, it would be hard for me to comment on the vision, but we know that patients with MOG antibody optic neuritis is very common, the most common manifestation. So it would be worthwhile them seeing a neuro-ophthalmologist to see if they've been developing episodes of optic neuritis too.
Okay, great. That makes sense. So another question is that this person is 5 years out from their TM diagnosis. If they were to have an MRI of their spine now, would there be evidence of damage, prior damage to the cord? And if so, how would this differentiate from an acute attack? I know we talked a little bit about this, but if you could comment.
Yeah, no, I think to reiterate that is fine. So it depends a little bit on the cause. So if the cause, for example, was aquaporin 4 antibodies or MOG antibodies, they oftentimes the large lesion that you see with lots of inflammation initially and lots of contrast enhancement, When you do the repeat imaging, the lesion will often be much smaller or may even be gone away, and the contrast enhancement that tends to come with the active inflammation will often be gone away. And similarly, if it's an MS lesion, the lesion may be big initially with the contrast enhancement and then may go away. But the MS lesion seems to be more likely to leave a scar within the cord. So it'll look a little bit different, and sometimes there can be some thinning of the spinal cord in that area left over, so that in the acute situation, the lesion is swollen from all of the active inflammation, and then later on, there's a little bit of thinning in the spinal cord as a residua of that inflammation.
Okay. And then how often do you see complete resolution of lesions in mog-associated myelitis after treatment?
So that's an excellent question, and that's actually our latest research project. We're looking to see how commonly, I would say probably in our preliminary experience, probably 60 to 70% resolve, and then the remainder, the lesions are usually much decreased in size, and sometimes there's a little bit of signal abnormality there. But that's certainly an area of active research of ours at the moment.
Okay, great, thank you. And then how can TM caused by Sjögren's syndrome be differentiated from TM caused by MS? Is there a way to tell that?
Well, I think when you have a patient with Sjögren's syndrome and they develop transverse myelitis, you have to consider testing for aquaporin 4 antibodies in the blood, because Sjögren's syndrome and neuromyelitis optica spectrum disorder associated with this aquaporin 4 antibody often coexist. So in a patient who has that, we usually recommend they're tested for the aquaporin 4 antibody, and many of those patients end up being positive. And then it's the aquaporin 4 antibody that's causing their syndrome. So we know, similarly, if we think about patients who have autoimmune disease in general, a patient who gets type 1 diabetes is more likely to have thyroid problems. But that's not their diabetes attacking their thyroid. It's two separate diseases that tend to run together. So that's one thing. And then, if it is the aquaporin 4 antibody positive with Sjögren's, the lesions tend to be longer. So they will extend more than that 3 vertebral segments. When you look on your MRI, your radiologist shows you the picture. You'll see your vertebrae. You'll have multiple bony vertebrae in your back. And if it extends longer than 3 of those vertebrae, that's very suggestive of this aquaporin 4 antibody disease. And definitely they should be tested for that if they have Sjögren's syndrome. If the antibody is negative, then we have seen cases where Sjögren's syndrome is associated with myelitis, but I think testing for the antibody would be most important, yeah.
Okay, thank you. And then are there any specific considerations when a child is getting an MRI as opposed to an adult?
There are. I think it can be more difficult for a child to stay still in the MRI, so sometimes we need to put them under anesthesia, particularly if they're young. Otherwise, children can also receive contrast, so I don't think that would be a big issue. Sometimes seeing abnormalities within the brain, in very young children, there can be changes of myelin development as the myelin is growing, that need to be differentiated from, abnormalities of MS or other things. So I think they're probably the major differences, yeah.
Okay, and I know at the beginning you mentioned about imaging myelin, but if we can talk a little bit more in detail about that. Is there a way to image myelin, or is it too small, or what are the reasons that we might not be able to image myelin?
Yeah, I think it's difficult for us to see myelin specifically. It's quite small, and it covers all these, what we think of as these axons or electrical cables. So it's like the copper insulation on your wires. And when you have multiple, you're talking about millions of wires, all with their own insulation within the spinal cord, it's hard to see individual myelin. So that's something we have to see under the microscope. But in saying that, we have such good experience with all these diseases that, if I see a spinal cord full of MS lesions, I can recognize that no problem, because it's kind of a pattern recognition. And we know from our experience that when we see that pattern, that's going to be demyelination on the MRI, and that's going to be MS. So I think with experience, we can often predict that that's likely to be demyelination, but you can only really see it under the microscope when you stain it with certain stains under the microscope. And we don't like to do biopsies of the spinal cord because the spinal cord is kind of prime real estate there, and any sort of taking any tissue from there could result in paralysis and make things worse. So we generally don't do any spinal cord biopsies, but that's the way we would see it.
Okay, great. Thank you. And if you could talk a little bit about maybe what the future of imaging looks like. Are there any improvements that you know of that might be coming in the near future, or you know, what the future holds kind of for imaging?
Yeah, you know, I think imaging has improved a lot, even over the last, 20 years or 30 years since I suppose MRI has been around. You know, the discovery of MRI was a huge benefit for all of us in the field of MS and transverse myelitis, and really allowed us to see all these lesions. And what we've noticed over time is that the quality of the imaging is improving such that we can recognize different patterns that go with different diseases. While previously the imaging quality was poor, it's just like the imaging quality in your TV with high definition and things like that. We can see things much clearer, which gives us a better sense of what the diagnosis is. In terms of the future, you know, I think some of these imaging techniques that we mentioned earlier, the diffusion tensor imaging, we're getting better at. We're getting better in the brain at looking at cortical lesions within MS and some of those other diseases where previously they were difficult to see on the MRI. So I think technology is improving all the time, and I think the improved quality of MRI over time has really helped us in understanding the diagnosis in these cases.
Okay, thank you. And we just got a question asking about, you know, why is it that in MOG-associated TM, or I would also say in NMOSD, why the lesion can be so extensive or so long?
Yeah, we don't really know exactly why that happens. We know that there are certain regions that seem to be a bit more predisposed, and we're not sure if that's related to, with the MOG, for example, it's a bit unusual in that the gray matter seems to be a little bit more involved, while the white matter, where a lot of the covering of the nerve, the myelin, is located, tends to be less affected. So it's something we don't really understand well at the moment, but what we do know is that from our experience when we look at these cases that we know it can help us in the diagnosis. So where it's really useful is when a patient has their first episode, is it a long or is it a short lesion? What is the pattern of enhancement? How can that help tell what the underlying cause is? But in terms of why that happens, we're less certain. And, we know a little bit more about the aquaporin 4 antibody and the MOG antibody, I suppose, because we know that those antibodies are specific targets and in some cases cause the disease. With MS, we know even less because we don't know the exact cause. So there's plenty more for us to learn over time, I think.
Okay, thank you. And if someone has been diagnosed with longitudinally extensive transverse myelitis, so more than 3 vertebral segments, does that kind of point you towards thinking it might be something like NMO, or does that happen also in idiopathic transverse myelitis?
So what I would say is that would point one towards testing for the aquaporin 4 antibody and looking for this NMO spectrum disorder. With MS, the lesions are very rarely long, so they're almost always short. So it's very helpful to distinguish from MS. But there are lots of other things that can cause long lesions, lots of other causes of transverse myelitis, including idiopathic transverse myelitis, sarcoidosis, MOG antibody disease. So there's a whole range of different disorders that can cause long lesions. So what it does is it helps the doctors kind of narrow the diagnosis away a bit from MS and more towards some of these other causes. But there's lots of different causes of long lesions. So if they test for the aquaporin 4 antibody and it's negative, then what sometimes we see is the doctor says, well, the antibody is negative, but it's still this NMO spectrum disorder. But I would warn people to be careful in that situation. You need to look for other things because there's lots of things that can cause long lesions. So it's important to do lots and lots of testing in that situation if the antibody comes back negative for the aquaporin 4. Yeah.
Great, thank you. And can imaging be used to tell if an acute treatment is working, or is imaging not really used for that purpose?
I think so, yeah. We will often do a repeat MRI. Sometimes we'll treat patients with steroids or plasma exchange. And then when we do a follow-up MRI, we often do it to see, is the patient getting better? For example, if people are very severely paralyzed, and sometimes it can tell us that the treatment has worked, or it can tell us that, listen, we're barking up the wrong tree, and in fact, the MRI looks worse, and, this treatment is not working. Maybe we need to reconsider, was this a spinal cord stroke? Is it not inflammation? So repeating the MRI can be useful in the early stages in that situation, yeah.
Great, thank you. And then is there any research being done using imaging, whether it's at Mayo Clinic or elsewhere that you know about?
I think so. There's lots of people looking at the stronger magnets. So the 7 Tesla magnet is something that they're looking at more in the brain than the spinal cord. We're also looking at, we've collected a lot of patients over time. So we're looking at the patients that we do have with MOG antibody and trying to see what are the differences from MS. How can we differentiate the brain MRI of a patient with aquaporin 4 antibodies from MOG antibodies from MS? And this is something we're always trying to do so we can help doctors who see these patients to recognize which disease it's likely to be. So there's lots of research going on. We're looking at lots of the patients who've already had MRIs, and then we're also following some patients who have had MRIs and seeing what happens to them over time. How do those MRIs change? So I think there's lots happening in the field in that area. And then we have new techniques like the diffusion tensor imaging that we're looking at in terms of learning more about those specific tracts. Yeah.
Great, thank you so much. And so, we are towards the end of our questions. Was there anything, that you feel like we didn't cover that we should talk about imaging and its role?
No, what I would say is that for patients out there who have had a diagnosis of transverse myelitis, that and there's no cause found, that they should talk to their doctor, get their doctor to look back at the MRI, their neurologist, and say, does it have a pattern suggestive of some other disease? Can we figure this out? Because when we did a study at Mayo Clinic, we looked at patients who were referred with transverse myelitis of unknown cause. And in about 70% of those patients, we were able to figure out the exact cause. So I think, and the same would be true at other myelopathy centers. So I think the message out there to patients is if you have a transverse myelitis and they don't know the cause, it's worth going back to your neurologist, having them relook at the MRI. Is there a cause that can be found, or is there ongoing active inflammation? And if they can't find a cause, then maybe, they should refer you to an expert center. And there's many expert centers, MS centers or transverse myelitis clinics around the country that they could go to try and figure that out. So that would be my kind of message to patients out there who have transverse myelitis of uncertain cause, that, do go back to your neurologist and do seek out an opinion to see, because oftentimes we can find the cause. Yeah.
Great, thank you so much. We covered a lot and answered a lot of questions, so I really do appreciate your time and being here to answer these questions from our community. We really appreciate it.
Oh, well, thanks for the opportunity, and it's great to be able to talk to the patients out there who have this unfortunate disease, and we learn so much from our patients, so we're grateful to them all for sharing their cases and the patients we get to see in our clinic. So thanks very much to them.
Thank you so much. Bye.